Hello everyone, thank you for joining. I'm Paula Zimbran. I'm a psychiatrist at Yale School of Medicine and at Yale Center for Excellence for Wilson disease. In the past 5 years, I have consulting for Alexion, Ultragenyx, Vivet, and Ancientium in matters related to Wilson disease. In addition, in today's presentation, I will mention some use of psychotropic medications for indications that have not been approved by the FDA. I was asked to talk about anxiety and depressive disorder in Wilson disease. So I will start by some general notions about anxiety and depression, and then talk in more specifics about how these conditions can present in Wilson disease in terms of prevalence and significance. Psychiatric symptoms in Wilson disease are very common, and they can occur at any stage of the illness. At initial presentation, sometimes even in the absence of hepatic or neurologic manifestations, and up to 70% of patients will experience some psychiatric symptoms during the course of the illness. Also, psychiatric symptoms can occur after initiation of decoupling treatment, most commonly with penicillamine. Comorbidities are very common, with about 40% of patients meeting criteria for more than one disorder. The psychiatric symptoms are important because they can impact negatively the quality of life. They can lead to delays in diagnosis of Wilson disease, especially when they occur before liver-related symptoms or neurological symptoms. And they can also impact the patient's ability to adhere with a treatment regimen for Wilson disease through delusional thinking, through cognitive difficulties, or through changes in judgment, such as underestimating the risk of not following the treatment. Let's take a quick detour and talk about anxiety and anxiety disorders. As you can imagine, not any experience of anxiety, even intense, equals with a psychiatric disorder. Anxiety is a human emotion that can occur in various circumstances. Sometimes is actually desired, such as having anxiety in front of a real danger, because it triggers self-preservation and it triggers behaviors that are actually adaptive. Severe anxiety becomes an anxiety disorder when there is a specific pattern of symptoms that is intense, repetitive, and leads to some form of functional impairment. And these are some examples of anxiety disorder. The generalized anxiety disorder are people who worry a lot and cannot stop worrying, who, because of the excessive worries, cannot rest, cannot relax, cannot concentrate well, are permanently tired. Panic disorder occurs when panic attacks occur in a repetitive fashion and lead to significant anticipation, anxiety, and avoidance. Same with social anxiety disorder. It's marked by sometimes total avoidance of social situation, and in addition to anxiety, a persistent fear of being scrutinized or judged. Then we have agoraphobia and specific phobias, which are intense fears of specific situations, often marked by avoidance. In severe agoraphobia, patients do not get out of the house for years, and they find a way of surviving by bringing their necessities to them. As I mentioned, these are some examples of anxiety disorders, and as you can see, they're typically cluster of symptoms that occur for a specific period of time and lead to functional impairment. Some of these disorders and anxiety in general can present with physical symptoms, which can confound the picture when one has also another medical disorder. For instance, panic disorder can present with chest pains, pounding of the heart, palpitations, sweating, tremor, or chest pains, or even gastrointestinal symptoms, which can confound the picture or can lead to unnecessary medical investigations, or on the contrary, can mask presentations of acute physical illness. Same with depression. Not any experience of sadness, depressed mood equals the psychiatric disorder. Grief, for instance, is a period of significant, persistent sadness that leads to changes in behavior often, but it's not always seen as a pathological condition. Some examples of depressive disorders are listed here, such as perinatal affective disorder or postpartum depression, major depressive disorder, which is probably the most serious and can lead to more severe consequences. Dysthymic disorder, grief, persistent depressive disorder, or otherwise known as dysthymic disorder, occurs when a person experiences depression, which is typically not very severe, that lasts for a long time, usually at least 2 years. It's important to distinguish depression with symptoms of psychosis or bipolar depression, which is a depression that occurs as a part of a manic depressive illness, because treatment for these distinct types of depression is also different. Let's talk about the steps towards obtaining a diagnosis of anxiety or depressive disorders. The mental health clinician will take a detailed history of the potential symptoms, how long ago they started, how did they evolve, what makes them better or worse. And these symptoms could include specific emotions or affective experiences, physical symptoms, or cognitive schemas, which means we look at how the thoughts connect together and how they connect to reality. This phase of the evaluation may include, with the patient permission, interviewing a family member, as often family can know things about us that we might not be able to relay to the therapist, or a review of medical records. There will be an assessment of potential functional impairment. How do these symptoms impact one's life? Probably the most common thing we see as functional impairment is some degree of avoidance, especially with anxiety disorders, which is avoiding certain situations or anticipating the recurrence of anxiety and then building a life that would exclude that specific situations from it. It is important always to rule out potential causes such as medical conditions that can cause the symptoms and substances. Very common patients with panic attacks are seen in the emergency rooms and they receive a cardiac workup to ensure that there is no acute heart condition. Substances can also cause both anxiety and depressive symptoms. And by substances, we mean not only psychoactive substances like illicit drugs or legal drugs or alcohol, but also medications, which can cause psychiatric symptoms. And by putting all this together, we reach a diagnosis of anxiety or depressive disorder. We divide the interventions for anxiety and depressive disorders in two main categories. One is so-called biological treatment, the other category is psychological treatment. That being said, there is extensive evidence that psychotherapy, talking therapy, also impacts the structure of the brain, which is often connected with its effectiveness. Biological interventions include medications and also what is now described as interventional psychiatry, things like shock treatments, electroconvulsive therapy, transcranial stimulation, and intravenous agents like ketamine. However, the most commonly used biological interventions remain antidepressants, which are the treatment of choice, first-line treatment for both anxiety and antidepressive and depressive disorders. Other psychotropic medications can be used either for short-term until antidepressants have full effect or as adjuvants to antidepressants. Psychological interventions, talking therapy, are also of different duration and with different focus. These are some examples of cognitive behavioral therapy, psychodynamic therapy, which can be short or intense, or also the traditional, more long-term psychotherapy, interpersonal therapy, which focuses on relationships. And all these can occur individual or in group, can occur for short-term or long-term, in person or therapist guided, but there is an increased offer of online psychotherapy interventions. What we know about depressive disorders in Wilson disease, and I want to throw a word of caution there because there are a lot of studies or materials that are talking about depression in Wilson disease. And it's important to understand that many of those studies or articles or reports actually describe depressive symptoms. And just a minority of those studies actually looked at the diagnosis and that was made in a accepted methodology. These are some examples of studies that actually used validated measures and assessment tools to make the diagnosis of depressive disorders. As you can see, the major depressive disorder is reported to have a wide range of prevalence, between 4% and 47% in patients with Wilson disease. It is important to understand that depression persists in about a quarter of patients, even later in the illness. And also, bipolar depression must be considered, as a significant amount of patients with Wilson disease meet criteria for bipolar disorder, as you can see, up to a third. And the reason why it's important is that the treatment for bipolar disorder is different than treatment for major depressive disorder or other types of depressive disorders. Our report of that was generated from the data collected with Wilson Disease Registry and was published last year. And this was based only on the initial assessment, so the first visit in the registry. We found a lifetime prevalence of major depressive disorder of 37%. Just to give you a term of comparison, in general population, the lifetime prevalence of major depressive disorder is considered to be around 15%. It is important to know that patients who, and I didn't include this on the side, but when patients reported a history of depression, that correlated highly, like more than close to 90% with the assessment done by a professional of a lifetime of depressive disorder. Which speaks to how insightful and knowledgeable patients with Wilson disease often are. Lifetime major depressive disorder correlated with worse mental health quality of life, but not with physical health quality of life. And also, there was no differences in major depressive in patients with cirrhosis or without cirrhosis, and major depressive disorder did not associate with worsened physical status. It is also important to note that major depressive disorder often occurs in the beginning of Wilson disease. What we can understand from these findings is that major depression in Wilson disease is not just a reaction to the impact of being sick or being disabled or maybe having to adjust the work schedule. So it's not a psychological reaction because something happens early in the disease before the social consequences of the disease. So this points out to the fact that there must be some biological impact that occurs with brain changes in Wilson disease. This study looked at psychiatric symptoms in patients with hepatic Wilson disease and with extrahepatic Wilson disease. And not surprisingly, feeling all the psychiatric concerns were higher in patients with extrahepatic Wilson disease. As you can see, anxiety was highly prevalent. Anger was also reported. Feeling sad or depressed also reported in over half of patients. In terms of anxiety disorders, again, this is the analysis of the first assessment, the initial visit. Agoraphobia was present in 13% of patients, which is similar with general population. Generalized anxiety disorder also present, but this was the 6 months prevalence, was not the lifetime prevalence, in 17% of patients. And there was an association between presence of lifetime major depressive disorder and anxiety disorders. This study looked at the correlation between presence of depressive or anxiety symptoms and difficulties with adherence. And as you can see, there were no statistically significant differences between patients with anxiety and depression in terms of their ability to adhere with treatment. Treatment for psychiatric symptoms in Wilson disease can be classified in two major categories. One is primary treatment of Wilson disease that you're very familiar with, and specific psychiatric intervention. About a third to one half of psychiatric symptoms in Wilson disease improve with just a treatment of Wilson disease, usually chelation therapy or zinc alone. But in some cases, there's a need for more specific mental health intervention, which could be either psychotropic medications or psychotherapy. Typically, we think of considering psychotropic medications where symptoms are very severe, impacting a patient's safety or leading to patient being gravely disabled. Also, when symptoms don't remit after a reasonable amount of treatment for Wilson disease. But there are some precautions that must be taken because there is a higher incidence of neurological side effects with psychotropic medication in patients with Wilson disease. So start low, go slow. It's an important principle to keep in mind. Trials of various or case report of use of various psychotropic medications have been reported in Wilson disease. In general, we pick agents that are less likely to cause neurological side effects, including memory difficulties, but also they have no risk of toxicity to the liver, and also, if possible, that are only partially metabolized or even not at all metabolized or excreted through the liver. And this is a recent study, very optimistic study reporting impact of liver transplantation upon psychiatric symptoms in Wilson disease. And as you can see, anxiety didn't improve much with transplantation, but depression in this group improved significantly, as well as specific phobias. But for phobias, the number of cases was too low to draw any conclusions. Psychotherapy in Wilson disease is very important because it does not have a risk for side effects. Some common themes that are addressed in psychotherapy are loss of physical abilities, loss of status, loss of social role, anger at the situation. And in general, psychotherapy is more likely to be recommended when patient is able to communicate, is curious about his or her own thinking. There's a desire for a change, either behavioral or psychological. There's no severe cognitive impairment, as most of psychotherapy work involves learning and remembering. And the physical status of the patient allows the patient to participate in session, which involves at least 30 minutes of being able to sit and engage in a conversation. Oftentimes, psychotherapy or psychotropic medications can address other psychiatric comorbidities, such as substance use or post-traumatic stress disorder. In summary, Wilson disease can present with psychiatric symptoms in the absence of neurological or hepatic presentations. Psychiatric symptoms are often reversible with treatment alone. Specialty treatment can be sought when symptoms are severe or do not remit with Wilson disease intervention. And there are specific cautions to keep in mind when implementing psychotropic medications in patients with Wilson disease. All right, thank you all for joining. I'm Paula Zimbran. I'm gonna try to answer as many questions as possible during the few minutes that we have left. There are a number of questions that came in. Thank you to all of those who wrote. And let me start with the first one, which says that you mentioned psychological symptoms occurring after decoupling with penicillamine. How long can you expect this to happen? And also, can symptoms arise once stable on treatment? Psychiatric symptoms during treatment with penicillamine, it's been reported in several cases. So for the way we kind of think of evidence-based conclusions, it's a relatively small number of cases, but it's still something that we're watching during treatment. They all occur within the first few weeks, around like 2, 3, up to 6 weeks of treatment. And I'm not aware of any case that occurred after years of penicillamine treatment that were related to the medication in itself. In general, to consider a side effect related to medicine, it has to occur within a time frame from beginning of treatment, and also must resolve with stopping treatment and must reoccur again with rechallenge. So those are the criteria by which we consider a symptom as caused by medication. Related to this, the question also asked about could this psychiatric side effects be related to relocation of copper in the brain? And there were a couple of other questions that were similar in the sense of asking about, are the psychiatric symptoms in Wilson disease related to the excess copper in the brain? The answer is probably yes. We still have to learn exactly what change in the copper location or quantity or function is related to Wilson disease. We know that copper is essential for brain function in many ways. It does help some of the enzymes that produce the neurotransmitters, which are the molecules that connect the neurons and allow various brain functions to occur. Copper is also essential in the function of astrocytes, which are brain cells that kind of help clean up the brain from sort of toxins or products that are not used by the neurons in the main brain functions. Of course, any change in the in copper, a change in copper can result in psychiatric symptoms. Copper is also researched now as playing a role in other psychiatric problems, especially in neurocognitive disorder, formerly known as dementias. The role there seems to be more in some other in the production of different types of proteins that are related to the mechanism of neurocognitive disorder. So still a lot to learn about exactly how the change in copper in the brain are producing the psychiatric symptoms. Why do you think Wilson disease patients suffer more with anxiety, depression? What are the reasons and causes? So what we know is that the prevalence of major depression is higher than in general population. And as major depression is reported early in illness when the disability, often when disability was not yet fully pronounced and the psychosocial consequences of the disease are not yet yet clear. That makes us think that it's more likely a biological predisposition, that the alterations of copper metabolite could predispose patients with Wilson disease more to depression. What about PTSD?
Dr. Cimbra, I'm sorry to say we are out of time. We have to move on to our next presentation.
All right. So maybe we could save the questions and I'll try. I don't know if there's a way to answer them in writing. I'm happy to work on that later.
Okay, very good. Thank you very much.
Thank you all.